Hello, everyone. My name is Don Self, and today we're going to continue the Business of Medicine series with a 1 hour webinar on increasing income in 2025 for the rural health clinics and the FQHC clinics. So let's get started. This should be fun. As you can tell, I have been doing this for almost 40 years, another 3 or 4 months, and it'll be 40 years, I believe. And I've really enjoyed getting a chance to do this for so long. I am the CEO of Don Self and Associates, and I am also the president and CEO and owner of Telecare USA, which is an RPM company. Most RHC and FQHC clinics have not been capturing all the income they can. Part of the problem is I believe that they're looking for money in all the wrong places. No, I'm not going to sing a country song to you, but if you're applying what we're teaching today, you should easily be able to increase the income of most of the clinics that you're in by 10 to hundreds of thousands of dollars a year. And I've done the same kind of a seminar, by the way, for fee-for-service clinics, and their increase is slightly more, okay? Except in the area of RPM. RPM, they have a higher area of increase or an opportunity of increase in income in rural health clinics. One of the big problems I'm finding is that a lot of RHCs and FQHCs are trying to treat their commercial patients the same way they do Medicare. In other words, an all-inclusive rate. And they're not billing out for everything that they're providing or they're doing in the service. In the clinic. And let's talk about that for a moment here. Medicare, they call it the all-inclusive rate, isn't really all-inclusive. According to the Code of Federal Regulations 405.2462, there are certain things that rural health clinics can bill out separately if they are providing that service. And I'm not just talking about labs or the technical aspects of the diagnostic testing. There's other services too that we're going to be hitting on today. Now, for commercial carriers, it's pretty evident whenever I look at the billing that they're not billing or providing all the services that the commercial carriers are willing to pay. And I'm going to go over some of those with you in a little bit. Another area that I'm finding that a lot of practices are doing, especially the RHCs and FQHCs are doing, and that is they're undercoding their office visits on commercial insurance claims. Somehow they think, well, it doesn't really matter on the Medicare AIR, we're going to get that flat rate. But on commercial claims, there's a big difference of income between a level 3 and a level 5. Now, sometimes that's happening because nurse practitioners in the clinic may be thinking, well, I'm only a nurse practitioner. I can't bill out a level 5, or commercial carriers won't pay for it. Yes, they do. In fact, a nurse practitioner can bill out any level of service when we're talking E&M visits as a physician can. Just make sure you're documenting it. The E&M today utilize the 2021 to 2025 rules, and that's basically real simple. Time versus medical decision making. Whichever one gives you the higher level code, that's the one you're allowed to bill. And that can make a big difference of the income, okay? A lot of difference on the income. So when we're talking about medical decision making, for instance, the number and the complexity of problems being addressed today is what we're looking at. And we're not counting those that the patient might have been treated on 2 or 3 years ago, only what's being addressed today. The second area we're looking at is an area of data. What lab test are we ordering? Which lab test are we reviewing? Are we talking to another healthcare provider about this patient? Are we getting information from a historian, a patient family member, etc.? That can make a difference in the data area. And in the area of risk, we're looking at what is the risk of complications and morbidity if we do a service, if we don't do a procedure, but we do a diagnostic test. Are we at risk, increased risk if we don't run that test? Are we at increased risk if we do run that test? These are the kind of things that we're looking at in the area of medical decision making. And that's why I created a tool. We created a tool several years ago called E&M Coding Tool. In fact, back in 1998, we had a similar kind of a tool that we ended up selling over the next 27 years, about 30-something thousand of these slide rules. And right now, we have thousands of people around the country that have bought these slide rules from us and use it. And it's just one tool after another that can make things easier for you. And it doesn't matter, honestly, if you're using this one, the A1 that put out by the AMA, another one by a different association, or whatever. I'm familiar with this one because this is one that we use, again, on a daily basis. Like in this area right over here, you're talking about the number and complexity of problems being addressed. Once more, in order to be addressed, that means that we need to be doing something on that particular diagnosis. For instance, in the low area, it would be a stable chronic illness or even a stable acute illness. In the moderate area, we could have two or more stable chronic illnesses. Patient come in with diabetes and hypertension, and both of them are stable. You say, okay, what's the definition of stable? That means that they're at goal. Like, for instance, I just had my doctor visit the other day, and I was at 134 over 80. Well, my goal is under 130 over 80. So technically, I'm not even stable, even though I've been staying the same blood pressure. It might be in the high area, where that would be a patient with congestive heart failure and their blood pressure is really high, their breathing is really low, the oxygen level is low. That could put them in severe exacerbation right there. Well, you got to figure out which of these areas we're going to find in that. And that's what, in fact, there's a free 15-minute webinar on how to use this tool at donself.com on the E&M page. So feel free to go to that page and help yourself. And that's, again, donself.com. In the area of risk, those are the area, oh, I'm sorry, in the data area, I forgot data, is we're counting how many tests that we're looking at or ordering, or how many discussion that we're having with other healthcare providers, or we in doing an independent interpretation of tests that was done by someone else. That might fall into the moderate area. If we're getting into the area where we have three or more of lab tests or diagnostic tests that we ordered or that we're reviewing. And then we also have a discussion management or a test interp with another healthcare provider that's not in our clinic. Maybe it's the radiologist, maybe it's the cardiologist, the gastroenterologist, whoever it may be. That may put us into the extensive area. And if you have a high area here and you have an extensive area here, it's automatically going to be in this area over here, high and extensive. As long as you have two of them, that's going to give you a level 5 visit. But let's say we had over here a moderate on the data and we have extensive on the data. Moderate on problems and extensive on the data. Then let's go over here to this area. Let's say we're just doing prescription drug management. We're adjusting the patient's metoprolol. Or we made a decision that we're going to keep the metoprolol at the same level for the next 3 months. As long as they made a decision regarding prescription drug management, we get to count that. So in that case, if we had two moderates, then we're automatically a level 4, either new or established patient, unless time gives us a higher level. Now, keep in mind, when we're talking time, we're talking about all the time spent by the medical practitioner, not the nurse and their other staff right there, but just the medical practitioner. That can be the physician, the nurse practitioner, the PA, etc. Of how much time they spent on that day. I'm going to go into greater detail on that one in a moment. And if we're talking about time counted for skilled nursing facilities or home visits, then we count additional days right there that we get to count. And you say, okay, why is this so important? It's because the insurance companies, especially the commercial carriers out there, are monitoring which codes you're using. And if you're documenting a level 5, by golly, you bill out a level 5. And so let's take a look at the time factor, by the way. What do you mean by time? When we're talking time, that's the time you spend preparing to see the patient before you go into the room and you're reviewing their chart, or you're talking to your nurse about information that you're getting from that on that patient. It may be with the person who drove them in and they're sitting in the reception area. You have to go out there and ask them questions. And then the time you spend performing a medically appropriate exam and or evaluation. Now, keep in mind with any E&M, this year, last year, even all the way dating back to 2021, when they made the major changes right here, you must have an appropriate history and or exam. You don't even have to have both. You say, well, what if I did an HPI, an appropriate HPI on every patient? Cool. In fact, that's what I generally recommend to my clients. Give me a history of present illness on that. How long have you had this? Is it dull? Is it sharp? Is it pain? How often do you get these pains right here on the scale of 1 to 10? What is it? Have you taken any medication to address that pain, etc.? What makes the pain worse, etc. That's all an HPI. So we get to count counseling and educating the patient and their family or caregiver, time you spend after the patient's left, ordering the meds, the tests that you're performing or that you're ordering on the patient, or any procedures that you're ordering, and the time you spend referring and communicating with other healthcare professionals, as long as you're not billing out separately for that, like a consult or something like that. But then most carriers don't pay for consults anymore, at least the 9924 to 9925 series codes. And the time you spend documenting the clinical information in the note as well as any time you spend independently interpreting results on that date. For instance, let's say you saw the patient that morning and ordered some lab tests and they didn't come in till the afternoon. So you look at the lab tests in the afternoon, wow, we get to count that time. And if you pick up the phone and contact the patient's family or the patient themselves, then we get to count that time as well. So count all of this time. But once more, it's only the time of the medical provider. And as I said, it's either time or medical decision making, whichever one gives you the highest level. You say, well, what if the time only gives me a 99203 level, but the medical decision making gives me a level 5? Then you bill a level 5 because it's the higher of the two. Well, if the medical decision making is a level 4, but you did this right here in 14 minutes, so you're only looking at time being a level 2, and the medical decision making being a level 4, then you build a higher level, level 4. One big problem I'm finding with, especially with commercial carriers out there, and that is when we're filing the claim to the commercial carriers on a CMS 1500 claim form for the visits, we're not documenting or we're not making sure that we link the right diagnosis to the right procedure. This is vital. Like, for instance, on what I'm showing you right here, you have a 99214 with a 25 modifier and linked to the very first one, A. You said, what about the others? They don't really count. All we're looking at is the first one. And then we're looking at an EKG listing linked to A. 69209 for removal of impacted serum to lavage. Means that's where you take the water or the hydrogen peroxide or the Dr. Pepper or whatever you're shooting into the ear to flush the wax out with. And that's linked to A on the right ear. Well, we look up here at A and we got pharyngitis. And then we've got, for the second diagnosis, hypertension. The third diagnosis, impacted cerumen. And so you want to make sure in this case, A would be for the pharyngitis. 93,000 would be a B right here for the hypertension. That's why we did an EKG. And we did the removal of impacted cerumen for C, which would be the impacted cerumen. And it's important that you make sure you link these, especially to the medical provider, because a lot of times I'm finding that the billing person or the coding person is guessing. And sometimes you can guess, but what if you had a lab test down there? Would you, as a biller, know which one of the diagnoses the patient ordered a CBC on or a CMP on? You might, because you might know your provider that well and you got into the habit of it. I wouldn't know because I don't know your provider, okay? A lot of times our doctors are wondering why they're not making enough money. Well, part of the problem out here is they're not doing what the carriers are willing to pay them lots of money to do. Or if they are doing it, they're not making sure that they report it appropriately to their billing staff. And a lot of money is being lost there. Sometimes it's just that we don't know what we can bill out for the procedures. For instance, in the area of removal impacted cerumen, you've got two codes. And yes, I even find certified coders get confused about these codes quite often. Now, what is the 69209? That's where you're removing impacted cerumen, again, by lavage. You're flushing it out. And that can be done by anybody in the office, a staff member, a medical assistant, nurse, or whoever. It doesn't have to be medical practitioner, meaning the doctor, nurse practitioner, or PA. And by the way, that code 69209 for Medicare and for commercial carriers is per ear. 69210, though, is a little bit different. That's where the doctor, nurse practitioner, or PA is going in there with a tool. That tool can be curette, a spoon, tweezers, barbecue tongs, whatever you're reaching into the ear to pull the wax out with. That's 69210. And there's a separate set of rules there. Where with Medicare, they expect to see where you use magnification also. And with Medicare, that's a per patient code. The only way you can get multiple 69210s on a Medicare patient would be if the patient came in with 3 ears. because that's for 1 or 2 ears. Where with commercial, 69210 is a per ear code. So you want to make sure you're billing it out 69210 LT or 69210 RT or 69210 with a 50 modifier, meaning you did both ears. That's important to understand that because the carriers, if you did both ears, you need to be billing for both ears. So double your fee, charge that unit's number 2, or give it an RT, LT on a line items if you want to. Another area I'm finding a lot of confusion on is destruction of lesions. And I find this in all kinds of offices, not just RHCs or FQHCs. And that is 17,000 is for destruction of one premalignant lesion. One, or basically the first lesion. And if you're doing 2, 3, 4, 5 lesions, and typically when patients come in to get actinic keratosis removed, they're having multiple 4 to 5 or 6 lesions destroyed at that time. So in that case, you'd bill 17,000 for the first code and 17,003 times 3 if you did 4. 17,003 or 17,003 times 5 if you did a total of 6. So you'd have 17,000 and 5 charges of 17,003 for the second through the 5th lesion. Make sure you're billing those out properly. Same thing with breast and pelvic exams. Don't give those right there away. They're separate. What about joint injection and drugs? Okay, are you billing those out? Because anytime you're doing a joint injection, that does not include the drug. You need to charge separately for the Depo Get Better or whatever it is you're injecting into the joint. And the same thing happens with the trigger points. If we're talking the 20552, 20553 codes, make sure you bill separately for the drugs as well. For intramuscular injections, you want to bill out the 96372 plus the drug. Let's say you have a commercial insurance patient who brought the drug in with them. How do you do that? Well, then you'd bill out the drug code with a 1 penny charge because you didn't provide the drug. But that tells the commercial carrier that, yes, this was the drug that I was injecting, which is why I billed out the 96372. RPM and CCM, that's for Medicare and for commercial carriers, extremely profitable. We're going to talk about that today. And the technical fees on labs and diagnostic tests, you get to bill out for those. And remember, the interpretation is bundled into the AIR. And that's why there's a difference between Medicare and commercial, where with commercial, you bill out the entire code. With, say, for instance, you're doing a spirometry in the office. A 94010, maybe a pre and post 94060. If it's Medicare, you're going to bill it out with a TC modifier to show that all you're billing for the Medicare is the TC side, the technical side. With commercial, you bill it out with no modifier, which indicates you did both. So you're billing out the full fee with commercial. Now, in 2025, we got some phenomenal opportunities in the area of care management. Now, we also had the same one this year, by the way. We had phenomenal opportunities this year, but a lot of practices have not been taking advantage of that. A lot of RHCs and FQHCs are very confused about this, which is why just about 2 weeks ago, John, Michael, Carter, and I did a 1-hour deep dive on the GO511, where we talked about the GO511 as well as other care management services. But it basically, you can bill out GO511 in an RHC or FQHC multiple times in a month for a patient. Say, for instance, you're doing a PCM or personal care management, or you're doing RPM, or you're doing CCM. You say, well, can I do chronic care management and remote patient monitoring in the same month? Yes, you can. And that means I'm going to bill each one of those with a GO511? Yes. And that's the way it is this year in 2024. Now, in 2025, for the first 6 months, you can also bill it out multiple times for the first 6 months of 2025. And I'll go into detail on that one. But this year, these are the codes you can bill out. Now, you bill out the GO511 for Medicare, but you'd bill out for the individual codes right here for commercial insurance. So we have, again, a difference between Medicare and commercial insurance. Now, in 2025, we have a new change. We notice over here on the RPM, remote patient monitoring, you have 99458, and that's the change in this year. in 2025. You say, well, what kind of change is that? It means you can bill out for the additional time. The same thing with the chronic care management, the additional time that you get to bill out for those. So you want to make sure you grab the income on those things as well, making sure that you document it all. Now, once more, you can bill out for the first 6 months in a rural health clinic and FQHC in 2025 for either the GO 511 or the individual codes. It makes more sense and makes more money for you in the RHC or FQHC world to bill out the GO 511. Why? Because the GO 511 has a higher allowed amount per each unit than do these other procedure codes. Now, the first 6 months is a transition period when we're talking about the GO 511. Again, January 1st all the way through June 30th, we get to bill out either, and I highly recommend, again, the GO 511. You say, okay, so what happens after July? Well, after July 1st? Well, in that case, you're going to bill out to each code individually because GO 511 is scheduled to go away right now. You say, could they change their mind between now and next July? They could. And with all the changes we're having take place throughout the entire government, we're cleaning house, it looks like, which I think we definitely need to clean house. With all the changes they're making with RFK Jr. or Dr. Oz or whoever's going to be running Health and Human Services in chronic care and CMM, Centers for Medicare and Medicaid Services, then we don't know what they're going to do, honestly. There's going to be a lot of changes taking place next year. I'm extremely excited about it because in most cases right here, this is going to be real positive news, okay? Now, GO 511, as I said, was being used for all the others, and it's being used for chronic care management, principal care management, chronic pain management, general behavioral health integration, RPM, or sometimes called remote patient monitoring or remote physiologic monitoring because you're monitoring the different physiologics. Remote therapeutic monitoring, typically that's performed by orthopedic surgeons and physical therapists and all like that. Community health integration, which can be by any provider. Principal illness navigation also can be with any provider. And then you've got the principal illness navigation peer support code. And in fact, we're going to have some more codes coming down this year on kind of peer support, you might say, care management as well. Now, so we're talking about how do you build these out? Let's say you're doing remote patient monitoring this year in 2024. Then you'd bill it out with 1 unit of a GO 511 if you set up the patient with a 99453 with remote patient monitoring and show the patient how to do it. Another unit of GO 511 for providing the equipment to the patient, which would mean that the patient's doing at least 16 days of testing. So that would be a second charge of GO 511. A third charge for your staff, somebody's staff spending at least 20 minutes on this right here. And then another one, if your doctor is spending 30 minutes a month checking the numbers, that's 99091. So in effect, you really could bill out 4 RPM codes this year. Or you could bill out 3 chronic care management codes. That would be 3 charges of GO 511. You say, when Medicare is looking at the claim, do they know what services were being performed with the GO 511? No, all they see is the GO 511. And make sure, by the way, you're not trying to double count your time. There cannot be overlapping or double counting of resource time on that. So you can't count that same 20 minutes you spent on chronic care management towards the RPM code. They need to be documented separately. So you say, I could bill out 3 GO 511s for that. I could bill out for BHI, 1 for that right there. I could bill out 1 for the CHI, and then I could bill out 4 for the RPM. So in 1 month's time, I could have a total of 10 charges. Yeah, not bad, by the way, at $72.98. Okay. And you say, this is a whole lot more money than I was led to believe. It really is. This is great. I love this right here. Now, as I say, effective January 1st, RHC and FQHC can build add-on codes on the care management services. For instance, an extra 99458 for an additional 20 minutes, $72 for another 20 minutes. Not bad. Also, don't forget that CMS and Medicare allows pass-through billing for care management services for the care management services. remote patient monitoring, chronic care management, advanced primary care management, which is a new service coming in January 1st. We're going to talk about in a little bit, and remote therapy monitoring. So that means that you can have somebody else provide the service and bill it out, or bill us for it, and then we bill Medicare and we get to keep the difference. Exactly. Well, how long has it been like that? It's been like that with chronic care management since 2016, because in 2015, when they came out with it, they were not getting enough doctors in the country to do chronic care management on the patients. So they basically in 2016 came in and said, okay, now you can job that out because we can't get enough doctors to do it, and just find a good company to do it, and it's profitable. So that's when they made that change. So it's been around for, well, about 8 years so far. Now, in 2025, as I say, an RHC can bill RPM services using HCPCS G0511 4 times for RPM, because next year we're going to be able to use out 5.3, 5.4, 5.7, and 5.8, since they're going to allow extra time for the additional services being rendered. An RHC could bill out chronic care management using HCPCS code G0511 3 times in a calendar month, once for each of these 3 codes. And this really does add up. Now, you say, okay, how can I verify this? Well, because they have this, by the way, on CMS's website. They've had it in the Medicare Learning Network, an update that CMS sent out to all RHC and FQHCs 2 years ago in 2022. And here's emails that I received from the RHC team, as well as an identical email from the FQHC team at CMS. And they both said the exact same thing. Wow. So we're talking about a lot of money right here. Yeah, I'm going to show you how much money we're talking about in a little bit. Now, the G0511 is not used for the new advanced primary care management codes. That's the G0556, 57, and 58. But you can continue to bill out the G0511 and get RPM done. Plus, you can bill out these codes over here for the advanced primary care management if they were done at the same month for the first 6 months of 2025. You say, what's going to happen after that? Well, you won't use the G0511 anymore. You're going to use the other codes for RPM would be 99453 through 99458, in addition to the APCM. Cool. All of this is making a big difference on your income if we're paying attention to it and doing it. For instance, ask your provider, how many patients a day do you see with hypertension, diabetes, or pulmonary problems of CHF that you might want to think about doing remote physiologic monitoring? You say, well, does that mean we have to go out and we have to buy the RPM devices? No. Some companies, like the one that I own, we put the devices in your office and you don't pay us a penny for them sitting on your shelf until they start making you money, until you're using them on patients and they're generating income. Like this monitor right here, that's the one most popular. This one does blood pressure and glucose both. For instance, my wife uses out here and checks her blood pressure with it. It transmits the data, then it turns itself off. She'll then poke herself, slide a little strip into the top of this glucose strip, touch it, it then checks her glucose, transmits the data, turns itself off. All the data goes into a HIPAA-protected portal that my staff monitors on a regular basis, many times a day, checking each one of those numbers. And if they're too high or too low, they notify the doctor's office if it happens. And we have scales and oximetry and blood pressure monitor, like this one individually fits in a purse easily, or even a little glucose monitor that fits in there. And we provide, by the way, the glucose strips to you, and the lancet and the lancing device as well, so that you can hand those to the patients. So if that device is sitting on your shelf and the patient comes in and says, hey, and the doctor or the nurse practitioner says, I want this patient to have monitoring because I don't really trust the numbers that they're giving me. I don't trust the fact that the patient's having to buy their own glucose strips at home and they don't want to spend the money, so we provide that for you. What if you were just to hand that patient a device and then let Telecare USA do the rest? That's what we have literally thousands of patients doing around the country, from Hawaii to New York, because the doctors have handed it to them and then notify us, and we automatically reach out to the patient for them. Now, as I said, CMS and Medicare allows you to have another company provide the care management services for you, and then you do pass-through billing. And it's been that way since 2016. Remember, some patients fib about their numbers. And as an example, I watched my father fabricating his own numbers as I was driving him to the cardiologist. He said if he doesn't do that, then his doctor yells at him and he wants to adjust his medications, etc. Remember, this is also something that must be automatically transmitted, not recorded and sent later. And some patients come and say, well, I've got a smartwatch right here from Apple, and it checks my blood pressure. Does that count? No, this is not a medical device. This is a watch, even though it does other things. And we use them for everything nowadays, it seems like. Even a whole Dick Tracy, talk on the phone type thing to your wrist. But it is not a medical device, so therefore you can't use watches. That's why we have specific devices. Trust me, I would love to be, I'd spend a lot less money if I just had to go out and buy watches and hand to the patients than we do with all these other devices that we're using. I would jump on that like a duck on a June bug. In 2022, by the way, only 4,305 of the 1.2 million medical practitioners in the country billed out for remote patient monitoring to Medicare. That's not very many. That's not even 1%. 4,000 out of 1.2 million. That's pretty bad. And yet Medicare loves it because it saves them money when you perform RPM on the patients right here. Based on a 4-year study they did from 2016 through 2019, they came back and showed patients had reduced hospital admits, reduced readmits, reduced emergency room visits, cost reductions on the patients, decreased A1C level, improved medication compliance because the patients are going to take their meds and do their testing if they know their doctor's checking the numbers because they don't want to be yelled at sometimes, okay? So that's why Medicare and the carriers like this, is because it's saving them money. Years ago, I had a widowmaker heart attack. It cost my insurance company $170,000 by the time they finally got me out and got me home. Wow. Don't you think they would have rather been paying $100-something a month to a provider or $200 a month to a provider instead of 170 grand? Yeah. Now, from January through June of next year, let's examine the income potential for you. $72.98 is the Medicare allowed amount in 2024. I won't know what the new allowed amount is going to be for GO511 code until December 9th. And I'm recording this right here at the end of November. In fact, tomorrow is Thanksgiving, to give you an idea. So at that time, I'm assuming it's probably going to go up. Why? Because haven't you read that they're going to be doing a 2.8% reduction? No, I read that, but I don't believe it. Why? Because there is a bipartisan bill, meaning that both houses, the Senate and the House, both Democrats and Republicans finally agreeing on something, that they're calling for and asking for a 4.7% increase. And we expect Joe Biden to sign that if they do pass it right there. So if that's the case, instead of getting a 2.8% decrease, we'd love to see a 4.8% 4.7% increase. Okay. We got to wait and see what they do. But if we just use this year's numbers, GO511 times 3 units, say it'd be a 99453, 9945457, and 199458 would be $218. Let's say we set the patient up this month on it as well. So we got 4 charges. It's $291. And if you're using my company, you're paying us $77.10 to do everything for you, including the equipment, providing the glucose and everything. So your net profit is going to be somewhere between $141 to $214, depending upon how many units. So if you have 200 Medicare patients in your RHC or FQHC getting this service, that's an extra $340,000 to $515,000. That's $500,000 a year just from letting someone else do the RPM for you. And then you're able to capture these things going on with a patient quickly, early enough, instead of the patients maybe not testing. Okay. What we do with every one of our clients is we send out a report at the beginning of the month, around the 4th or 5th each month. And this is important. So this is how you would calculate it out so you know which codes to bill out. And it's going to show you the patient account number. Maybe you're in the Epic system or ECW or whatever system you're using, their account number. Patient name, and you'll notice I changed the names right here because this was an actual report for one of my clients in Grand Prairie, Texas. And it also shows the date that the patient got their monitor and got started, how many days last month they tested, how many minutes last month my staff spent on it, or my staff counting plus the time your staff spent. Like 31 minutes on Robert Stack, 52 minutes on Jim Neighbors, Gomer Powell, by the way. Clint Eastwood, 35 minutes, Merle Haggard. And by the way, these, again, just names I made up. So you'll notice on this for Robert Stack right here, you can bill out 99454 if it was commercial insurance, or a GO 511 if it's Medicare. You can bill out another GO 511 for the time that staff spent on that. And then another GO 511 because they went over the 20 minutes. And by the way, that is a midpoint code. Oh, cool. So you're looking at three units of it. So you're going to make about $218, paying us $77.10. You're going to net about $141 on that patient. Well, like with Jim Neighbors right here, your net's going to be about 214, and it goes all the way down. And you see, there's something right here that's interesting. On Bruce Wayne, there's a zero there and a zero there, and there's a zero. Why? Well, because if we don't get that patient to 16 days of testing with us calling them to remind them, and that patient doesn't do it, I mean, our staff doesn't spend at least 20 minutes, and you can't bill out either one of those codes. And if you can't bill the code, we don't bill you because we didn't do our job. So you say, okay, well, there's a couple cases right here where we didn't bill them. Exactly. Now we want that patient to be testing at least 16 days in the month. And if they're not, after they've gone 2 months without testing, at least 16 days in the month, I'm going to ask you to have that patient bring the monitor back in. Call them and ask them either bring it back in or get compliant and then give that device to somebody that is, or send it back to us. We'll clean it all up, send you another device. And again, they just sit on your shelves. And you'll notice down here, your net profit after you're getting about $6,057, which would be 83 charges of GO 511, and then you're paying us $2,000. So your net profit's about $4,000 that month, just on 26 billable patients, because 28 patients, 2 of them weren't billable. That's not a bad net of $144 per patient, especially with somebody else doing all the work. Now, if you're talking about after after July of next year, you're looking at still making a net profit of about $103 a month per patient. And so that's about a $247,000, or almost $250,000 a year net profit after July of next year. And by the way, you'll notice how much your net profit is on your commercial patients, because that should be about the same as this right here, although commercials many times will pay a little bit more, depending upon where you're at and what kind of contracts you have with them. So we're talking about a real opportunity right here to increase the income of your practice. Now, you say, okay, what about stratified pay? What about this new APCM and others like that? We're billing APCM on that. And let's say we stratified the patient, we use GO 511 for 99490 for a CCM, or we build out the new G0056 code. You're still looking at about $36 net profit on chronic care management. And if you're paying a chronic care management company, about $36 for that, you're looking at about $33 net per patient per month. That's still another $88,000 a year net profit just from doing chronic care management or the new APCMs. So don't discount doing chronic care management. You say, okay, well, this year, as of July of next year, what would you make? With a 99490, it's about $60 with Medicare expense being that, is make about $24. You're still going to make after July of next year about $57,000 net profit with someone else doing all the work. You say, what if I want to get involved with chronic care management? Because I understand it really helps the patients and patients love it. Reach out to us and we'll walk you through either how to do it in your own office, or we have a couple of different companies that provide that our doctors absolutely love. Okay. Also, don't forget that during the annual wellness visit, Medicare expects the expects the providers out there to detect cognitive impairment. They don't specify how. So some providers, what they'll do is they'll give the patient 3 words to remember. And then they'll have them draw a clock and they ask them different questions and they say, okay, what were those 3 words? Well, it was an airplane, a bumblebee, and a pickup truck. Okay, cool. Does that really tell you everything you need to know about that patient on the cognitive? Not really, because cognitive testing right here goes way beyond that, and it's extremely profitable for you. And there's other problems that can be causing similar symptoms. And it may not be Alzheimer's or dementia or something like that, organic brain syndrome. It can be depression or anxiety because back in 2016, those were placed on the list of cognitive impairments. It can be medication side effects. I know whenever I was taking problems, I was taking Vestavil for my sleeping problems after I had a heart attack 8 years ago. It dropped my cognitive skills, cognitive ability down huge. I felt like my IQ dropped 25 points on that right there. It's a big difference. It can be problems with the eyesight or hearing is making that patient believe that they have cognitive issues or the provider to think that. It can be urinary tract infection or chest infections. You say, what is urinary tract infections? Yeah, my mother-in-law, before she passed away, every time she got a UTI, she really went into Never Never Land with her cognitive abilities. Okay. Can be severe constipation, thyroid problems, stress, or even iron and vitamin deficiencies. You say, okay, so how do you recommend we test on this right here, Don? There's a test you can do in the office right here because CNSVS, and I've been using them since 2012. And your Medicare, your CPT codes on commercial insurance, you're looking at what we call the 80th percentile. And that's what I'm talking about right here when I say 80th percentile. You say, what does that mean? It means it's the 80th highest fee that is charged out of 100 fees charged by providers for these codes. And that's a number that's used by most insurance companies when they tell an insurance, they tell the State Board of Insurance that we're going to pay about the 80th percentile. Then that's what we're looking at is we take a look at the fees that's going into the carriers and find out what the 80th percentile is. CPT 96138 is about $71. CPT 96139 is only $1 more. But together right here, we're talking about like $143. And you say, well, what kind of a test is this? It's about a 30 to 35-minute test, maybe 45-minute test with the patient, depending on how long they take, in your office on a computer. And this isn't just senior citizens. Keep in mind that it can be anybody that's taking sleep medicines that you want to check and see, do they have cognitive issues or depression or anxiety? What percentage of your patients this year has had anxiety or depression because of the election? Oh my gosh, the wrong person was elected. Oh my gosh, my person didn't get elected, or their family member turned them away because of who they voted for. The inflation this year. I mean, we've had 22% inflation over the last 4 years, and people are struggling right now. That can be the problem of it. So you take a look at all these younger age patients right here that the insurance companies will pay for it. You bill it out, you pay about $35 for the test. So you still ended up making over $100 for that. And then you go over the results with the patient, which there we go, is a Medicare the 80th percentile on that one. So you're looking at about $387 minus 35. You're still looking at about $352 net profit. That's not too bad. And if they're doing one a day, that's an additional $95,000 a year or $7,920 a month. And this basically, we're looking at how quickly the reaction time is, their memory, symbol fluency, executive function on the patient. And that's a real good indicator on whether or not they have dementia or not. And you say, well, what if they do have dementia? Can we treat it? Yeah, there's ways of treating it. In fact, there's code 99483 for cognitive assessment and care planning. And if the patient has some kind of a cognitive issue, it doesn't have to be, again, dementia. It can be ADD, ADHD, bipolar. It can be anxiety, depression. All of those fall within cognitive impairment areas. Then you build that out and notice what the 80th percentile is there on that one, about $378. So if you're doing one of those a day, that's another $8,500 a month. And overall, if we're doing both the testing and we're doing this, That's about $197,000 a year. Now, is that going to help y'all pay the bills? Yeah, it really will. At the same time that I'm having people contact me all the time from rural health clinics saying, we're not making any money and we're trying to figure out how to stay open. Hospitals are having the same problem, by the way, and the hospitals can do many of these same services we're talking about, by the way. That's just, we have to educate them. So, well, what's included on the cognitive assessment planning? It was all of these services right here. And by the way, everything in red was already done by the cognitive tests that we recommend. And the company I work with on that will give you 5 free tests just to see if you like it. Take the test and see if your doctors, your nurse practitioner, like the way the results are and the results that they see and the ease of the test on the patients. You still have to do medical decision making of moderate to high complexity. That's easy. It takes about 4 minutes. Medication reconciliation if they're on high risk drugs, identifying the caregiver, what their ability is. Do they need any respite care? Do they know that there's social help in the area, support companies that will help them? And what tasks they're willing to take on and which ones they're not. Sometimes you don't really know what you're going to be doing until you're actually doing it. 46 years ago, when I asked my wife for her hand in marriage, I never knew that one day I was going to be giving her daddy a bath and I was going to be holding her mama on the toilet. But that's something you do as a caregiver to help family members out. So by doing these kind of things, not a bad extra income, 90-something thousand a year. Let's not forget the annual wellness visit, and which, by the way, is a record-keeping visit only. It's not an annual physical. Medicare has never paid for an annual physical except in a skilled nursing facility under skilled reassessment right there. And any licensed employee can do the AWV, but I believe that rural health clinics require the nurse practitioner be involved on everything, I believe. Again, I'm not an expert on rural health clinics, okay? But notice right here, they've been doing AWV since 2011. And notice the beneficiary copayment and deductible was waived by the Affordable Care Act for the independent physician practice evaluation. It's also called the Welcome to Medicare visit. And the AWV, and for Medicare covered preventive services that'll have a grade of AOB. You say, okay, so the patient doesn't have to pay anything out of pocket. Exactly. You say, what about those other services where they would have a copay? And the patient says, hey, I can't afford the copay because I can't even afford to buy food. Well, we're going to talk about that right there because there's ways you can do help those patients as well. By the way, if you're thinking that everybody's getting the AWV, they're not. In 2022, out of the 180,000 primary care providers in the country, and I don't have the numbers from Part A on the Medicare side from the RHCs, but just looking at it from the Part B side, only 73,000 or 40% of the primary care providers in the country that's billing out Part B did AWVs. I can't believe that that'd be that much of a difference with 40% in the fee-for-service clinics than the RHC clinics. And by the way, they only did AWVs on 25% of their patients. That means that 75%, no, they're not getting it. And that's kind of sad. Now, I mentioned a moment ago, what if the patient doesn't have the money to be able to cover the copay or their deductible, and you're wanting to do an RPM or you're wanting to do chronic care management or something else that doesn't pay 100%? Then what you can do is you can have the patient complete a form. You say, where do I find this right here? Well, under CMS.government website right here for RHCs and the FAQs, RHCs may waive the copayment and deductible after a good faith determination has been made that the patient is in financial need, provided the waivers are not routine and not advertised. It's not like you have up there, come on in, fill out a waiver. We're going to waive everything for you right here. Don't do that. I've seen doctors trying to do that and they got in trouble, okay? What you can do is download the hardship discount applications. And I believe I've got 5 of them, different ones, on my website on the free documents page. You go to donself.com, click up there where it says more, scroll down to free documents, and go to H for hardship. And there's 5 free ones right there. You can download those and make changes to them if you use them if you want to. Then you scroll down to the P area right there, for the letter P for poverty, and download the poverty guidelines. And then if the patient's within 200% of the national poverty guidelines, like in 2024, is like $60,000 for a family of four, or 49,000 for a family of three. If they're below that right there, they're within 200% of it. You can waive their copay and deductible. And by the way, this isn't just for RPM or CCM. It's other services that you may be wanting to do also that the patient needs help on. It's okay to give the patients that help. You're not going to get in trouble as long as you're following the guidelines. And that's why I showed you where where CMS said that right there. Majority, by the way, are not doing everything on the AWV that they should be, which is why I do a lot of training on one-on-one on AWVs. A lot of them are not performing the ancillary services that they can be doing at the same time that Medicare wants you to do. The depression screening, the alcohol misuse screening, the SDOH screening as of July of 2024 that came into being, the advanced care management, that they're not going over end of life questions and all like that. So, and some of them are not even documenting the AWV correctly. They're trying to document the same way as they would a E&M visit. And it's totally different documentation. There's different requirements you need to be doing. And Medicare is auditing and looking for those kind of things right there. They're even contacting your patients and say, what did they give you when they did the AWV? Well, they gave me a receipt. Okay, did they give you a 5 to 10 year screening schedule that shows you the date, the month and the year when you're supposed to get your next colonoscopy, the month and the year when you're supposed to get the next bone density, the month and the year when they want you to get another mammogram, etc.? Well, no. Well, then that means they're not doing what they need to, and they then go in and audit. But don't forget how profitable AWVs are. And sometimes I've talked to people that are saying, well, we use an outside service that provides it and they bill us. An AWV is not a care management service per Medicare. You can't pay another company to do that. Well, can I pay a nurse to help me and do that? Yeah, if that's you're paying an individual, not another company. So this is not one of those you can do a pass-through billing with another company on. You've got three different codes right there. GO402 is the Welcome to Medicare. GO438 is the first AWV that the patients had ever in their life. And then a GO439 is a subsequent AWV. So it's important that you make sure you're following the rules on those right there. Remember, at least 11 full calendar months must have passed since their last AWV. You say, I've had somewhere it's supposed to be 1 year. Is it 365 days? No. It's 11 full calendar months. As an example, this past March, I got an AWV. I believe it was on March 21st. You say, okay, when did I have an AWV before that? Last year. Last year's AWV in 2023, I think was like March 3rd. Okay. So 365 days passed, but no, March 9th, that past year. So 365 days had passed, but it didn't have to. Why? Because the previous year, I got it on March 14th. And you said, well, that wasn't full 12 months. No, 11 full calendar months would have been the end of February. So anytime in the month of March, I can get another AWV. And all Medicare plans pay. You say, well, there's commercial Medicare Advantage plans. They say they don't pay for it. They're required to. If Medicare Part B covers it, Medicare Part C is required to cover it, okay? And there's no copay or deductible on AWVs. And remember, your staff can do 90% of the work. So why is it that 75% of Medicare patients are not getting AWVs? It's because the doctors think it's too much work and they don't know what's included. One of the first things you have to do is complete a health risk assessment form. And I recommend that you have the patients complete this, whether or not you mail it to them and let them complete it in their at home, or wait till they get to the office and they're sitting in the reception area and hand it to them. And you say, well, isn't that a HIPAA violation? No, the patient's the one putting the data down on the paper. Let them do it. Or if you're using, another company out there that provides you an iPad and let the patient do it on an iPad, that's cool too. Okay. But just make sure that the patient's the one doing this rather than your staff taking 30 minutes going through all 4 or 5 pages of the assessment. And these are the kind of things that Medicare is looking for to make sure that they're in there on the health risk assessment form. Another problem I'm finding, a lot of practices, including rural health clinics and FQHCs, are charging less than what what carriers will pay for. And too many are thinking, well, I'll just bill out the allowed amount so I don't have any write-off right here. Well, you don't know what the exact allowed amount is going to be with some of the commercial carriers, the same way that a lot of fee-for-service clinics don't know what Medicare is going to be because they can change it throughout the year based off of economic index updates, the allowed amount updates, et cetera. So where do I recommend you go to get your fees? Generally, I'm going to recommend you go to Fair Health. Fair Health data is compiled of all the claims that's going into the insurance companies. They have to report that data on every CPT code so that you will know exactly what the 80th percentile is. You say, well, how can I access it? You go to fairhealthconsumer.org and you can put in up to 7 on one check on checking it on one ISP per week. You say, well, what if I check 7 on my computer and then I checked another 7 with an iPhone? Cool. And then I have my staff to check out 7 on each one of their home computers. Cool. By this time, you've got 28 or you got 35 or you however many codes you got. Go ahead and do it that way. You say, okay, what does this Fair Health data give us? It's going to show you what the 80th percentile is for in-network as well as out-of-network. You say, well, what if I just want to charge this in-network price, $84? Well, if you're in Anaheim, California, you're charging that less than what even Medicare would pay. Seriously? Yeah. Because you'll notice Medicare's allowed amounts 8851 up there. And you'll also, many times, you'll find additional codes like this 99497 is the first 30 minutes. 99498 is an additional 30-minute code. And they'll show you both of them. So go through and make sure you log all this down and you have the numbers easily handy for you. By the way, in 2024, you can't get paid for doing the vaccine administration separately than out of the all-inclusive rate. Starting January 1st of 2025, you can because you're going to get paid at a reasonable cost in RHCs and FQHCs because it's no longer going to be included in the AIR. So you want to make sure you bill those out separately starting January 1st. Overall, folks, you need to make sure you're billing out your E&M codes correctly. You're billing out all services, especially to your commercial carriers, because I know the AIR includes a lot of the services you're doing on Medicare, but don't discount that for your commercial carriers because that can be a lot of money right there. And go ahead and start selecting which patients your provider wants to do remote patient monitoring on or chronic care management on. And then make sure you're billing out and rendering the services on the AWVs the right way. And again, if you need additional information, you're welcome to reach out to me on that right there. I do a lot of training in these areas, okay? So you want to go through and make sure you're grabbing all of this income right there. If you ever want to, you can go check out our email listserv called Med Managers. We have over 1,100 billers and coders, office managers, medical providers. There's some physicians in there, nurse practitioners, PAs, etc. And that's basically you go to donself.com and scroll down on the main page where it says join my email. Or you can click on the link right here that you're going to get on the PDF right here. And that will take you and automatically let you enroll in it. And it's free to you. I pay Gaggle so that you can access it. And if you just want to schedule a time with me, go to donself.com and click on schedule at the top. And that way you can go ahead and schedule a time that you can talk with me. If you want additional information on Telecare USA, you can just go to telecare-usa.com. And that way you'll see all about our website right there. Or you can reach out to Don Self. You can reach out to me and I will go through and answer the questions for you on Telecare and get you set up. We appreciate this opportunity to spend this time with you today. And remember, we're here to serve you. So don't be afraid of reaching out. Our phone number, email, just reach out to us. We're here to try to help you in any way we can. And thank you for spending this time with us today. I hope you have a very blessed holidays coming up.